Good afternoon. First of all, I'd like to thank you for the invitation to moderate in this Meet the Expert session, optimizing lung mechanics in ARDS. And I will present the professors that we are going to talk it today. First of all, Professor Laurent Papazian from Marseille, France. Good afternoon.
Good afternoon.
Professor Neil Ferguson, Professor of Medicine from the General Hospital, Toronto University, Canada, and Professor Daniel Talmor from Massachusetts General Hospital from Harvard Medical School, US. And we are going to talk about how to optimize mechanics in ARDS. So we start with questions from myself, and then while we wait in the audience, the questions for the audience. The first one, I'd like to know what are the mechanical measures you usually take on your ARDS patients?
Well, maybe I can start, and we can go around the circle, please. I guess. We pay a lot of attention to respiratory mechanics, especially in ARDS patients, and a large number of severe COVID patients are no exception. So routinely, we are measuring the driving pressure, including a driving pressure in spontaneously breathing patients, which may be higher than the set airway pressure or the peak pressure. We also routinely measure P.1 and an occlusion and an expiratory occlusion pressure in spontaneously breathing patients. And of course, to measure the driving pressure, we're measuring plateau, so calculating driving pressure. So those are some of the numbers we pay attention to routinely.
Mm-hmm. Professor Papazian?
This is also our strategy, and especially when patients are ventilated using a control mode of ventilation, especially in volume control, we measure routinely plateau pressure, and we also evaluate total PEEP. And these two information are very important to calculate driving pressure. But and we try to keep the plateau pressure lower than 28 centimeters of water.
Mm-hmm. Professor Talmor?
So not surprisingly, I'm going to say that we also place esophageal balloons in pretty much any sick ARDS patient, and we use those numbers to calculate the transpulmonary pressure, both at end expiration and end inspiration. So we find that gives us a lot of additional information about the actual lung itself. And it's becoming easier and easier to do as the technology gets integrated into mechanical ventilators. So while not every patient would get an esophageal balloon, anybody who was at all sick would.
Mm-hmm. Good. I have a second question for you. The audience doesn't start yet. If you have an ARDS patient with a respiratory system compliance of 30 and another one with 15 ml per centimeters of water, do you have a different approach for one of good compliance and one of a very low compliance? If you measure at the first time you evaluate the patient, do you have a different approach, or you start with 6 ml per kilo and adjust the PEEP, respiratory rate? What do you think about that? We have to have a different approach or not? Neil?
I like to keep it simple. So it's one approach that can then be tailored to different patients. So I would typically start with 6 mils per kilogram. And yeah, if the patient's sick and it's early on, then maybe they're sedated and paralyzed and we're in volume control mode. And then we measure the mechanics and see where we are. Is in a patient who's got a very low compliance, that presumably will mean their driving pressure is very high. So then we would then take steps to figure out why that was, and reduce it if possible, right? So could we reduce their driving pressure or improve their compliance through recruitment, through higher PEEP, through prone positioning? Could we or do we go down on our tidal volume and accept higher CO2s with acceptable amounts of ventilation? But that would be the same approach I would do in a more compliant patient. I just wouldn't go in a patient with more compliance. Presumably, you wouldn't need to go down as far down that pathway. Which I also agree with Danny that might include trying to separate out what is the compliance driven by the lung or by the chest wall using an esophageal balloon. And we don't put them in everybody either, but in somebody who's challenging to oxygenate or ventilate, we would frequently use that as additional information as well.
Mm-hmm.
Yes, I fully agree with this strategy. And for patients with reduced compliance, probably we would use esophageal pressure measurement to assess lung compliance and to adjust ventilator settings, especially PEEP levels. Probably the approach would be different for patients with reduced lung compliance.
Mm-hmm. Professor Talmor?
So I would agree with Neil and Laurent that I would start in the same place for everybody, which is 6 mLs per kilo. But looking at it in the other direction, patients with good compliance may still have impaired oxygenation. And we did see quite a few of those patients during COVID, particularly in smaller women who 6 mLs per kilo would give them a tidal volume of 250 or 300 cc's. And in those patients, if they had a good compliance, we actually increased tidal volume and saw improved oxygenation with an increased tidal volume. We would look at the driving pressure as well. But in patients with good compliance, I'm generally not afraid, if needed, to go up to 8 mLs per kilo, if indicated. So I think we all start at the same place. And that is a point where you could either further reduce tidal volume or perhaps allow it to go up, since there is no real evidence to show that 8 is better than 6 or 6 is or the opposite.
Mm-hmm. Good. We have one question from the audience now. Since volume control rather than pressure control, is preference an advantage of one over other? Neil?
This is an age-old debate or question. I mean, I think generally the comment would be it's not the mode of ventilation probably isn't the most important thing. It's how you use it that is key. I like using volume control when the patients are early in the course of their illness, where we want to control the volume. It's very simple that way, and also you can facilitate sort of continuous monitoring of plateau pressure in volume control by adding a small end inspiratory hold or pause at the end of every breath. And that's what we would typically do. As patients start to progress and you want to wake them up and have them breathing spontaneously, then it becomes a little tricky, and you often see more dyssynchrony with volume control, I find, because you're not letting the patient do anything other than control the initiation of the breath. So we might switch to pressure control after that.
Mm-hmm. Professor Papazian, volume control or pressure control? The eternal question.
Yes, there is no great scientific evidence for difference between two strategies. And in our unit, we initially, during the early phase, used volume control, but after a few days, when we can decrease sedation, we use ventilatory modes in pressure, such as BiPAP or pressure support, for example. So it's related to the rules of the ICU, and there is no clear evidence of the superiority of one strategy on another.
Professor Talmor?
Yes, I would agree with both Neil and Laurent. There's really no evidence that in a careful physician's hands in a well-run ICU, one is better than the other. I think, and this is just a belief, that it's probably easier to go wrong with pressure control, with catastrophic loss of volume in unstable patients. So, but I think that both are acceptable. Personally, here we start with volume control as well.
Mm-hmm. Another question, it's one of my questions. When you have an ARDS patient with a high PaCO2, how do you manage the tidal volume and the respiratory rate? Do you go to 35, 40, 45? What's the limit, and what can you do or with a high PaCO2? You measure that space. What do you think about the management of a patient with a higher PaCO2, Neil?
Well, to start with, we've been tracking fairly routinely the ventilatory ratio in patients. That you calculate that by taking the actual minute ventilation times the actual PCO2 and divide that by a normal expected CO2 and expected minute ventilation. So a normal patient with normal lungs at a value of 1, and somebody with high dead space would have a higher ventilatory ratio. And we've seen some COVID patients with extremely high ventilatory ratios where there are minute ventilations of 15 or 20 liters a minute and still having CO2s in the 60s, 70s, or 80s. So I find that a useful measure to track over time to help see if is the patient getting better or worse in terms of the intensity of mechanical ventilation that they're requiring to remove CO2. We don't know really, I think, what the right answer is about what's the key threshold for hypercapnia or respiratory acidosis, and how much respiratory rate may contribute to elevations in mechanical. Obviously, it's a higher respiratory rate that does raise mechanical power delivered to the patient. So I think it's a bit of a balancing act between lowering your expectations about what you want the CO2 to be. I don't want it to be 40 with a pH of 7.40 in these severe patients. We'd much rather have a lower driving pressure and a lower intensity of mechanical ventilation and a higher CO2 than that. But exactly where that limit is, we don't know. I think there are observational data that show harm associated with high CO2, but there's inevitable residual confounding in those data that's hard to sort out. When is the right time to go to ECMO and things like this for ultimate relief? Still to be a little bit determined, I think.
Perfect. Professor Papazian?
Yes, there is no big worry when PaCO2 is around 50 or 60, and if pH remains higher than 7.30, for example. But if there is an association of hypercapnia and respiratory with severe respiratory acidosis, we can try to increase the respiratory rate, but there is a risk of of the problem of the evaluation and of we have to evaluate if there is an hyperinflation, dynamic hyperinflation, and we have to assess as PIP level, total PIP level. And in some cases, when with usual settings such as respiratory rate and tidal volume, it's impossible to obtain an adequate level of PaCO2 and pH. In some instances, there is an indication for CO2 removal, either by echo to air or by even by ECMO. You remember that in the Eolia trial, as a better result was obtained for patients with non-protective lung ventilation with severe respiratory acidosis. But as I said previously, it's only for a subset of patients, and many times we respect a PaCO2 level of 50 without any side effect, and we have to pay attention to right ventricular dysfunction, because with hypercapnia there is an increase of it's possible to obtain right ventricular dysfunction. We have to pay attention to right ventricular function.
Perfect. Professor Talmor?
Yeah, so I'd like to pick up on what Neil mentioned regarding mechanical power, which I think is a concept that really has legs and is important, and that's essentially adds respiratory rate to the calculation of lung injury and ventilator-induced lung injury. And it may be that, you know, this has to be handled individually at each patient's bedside. What is the right answer to increase the respiratory rate, or to increase the tidal volume, or to move the patient to ECMO? I think Laurence said very well that, you know, we can live with a PCO2 of 50 or even 60. And looking at the patient, at the individual patient, if their lung is relatively compliant and their driving pressure is not high, the answer may be increase the tidal volume. 6 mLs per kilo is, you know, we've kind of turned it into a religion, but it's not. And, you know, some patients do require slightly higher tidal volumes. So this is a question that can only really be answered at the individual patient's bedside.
Mm-hmm. There's another question for the audience now. What strategies do you have to control self-induced lung injury related to excessive respiratory effort rather than paralysis? What do you do rather than paralysis to control the respiratory effort? Neil.
I don't like how I'm up first for all these difficult questions. So I think that this is a challenging area, and you know, what you can do to limit inspiratory efforts in a patient who's breathing spontaneously may be limited, frankly, outside of paralysis is the short answer. We often will try different levels of PEEP. Sometimes higher PEEP can improve an expiratory lung volume and decrease drive and make the patient less air hungry. Different sedative agents may be helpful, but different patients respond differently. So propofol may be helpful in some patients. Others, we've had some success with dexmedetomidine. And finally, we're not infrequently using a technique of partial neuromuscular blockade in patients who were unable to control, who are still early in their disease. We really care about preventing larger tidal volumes or larger efforts, but we don't want to fully paralyze them, a smaller dose of a continuous infusion of neuromuscular blockade can allow control of the tidal volume or the effort without having the patient be completely paralyzed. And then there are other times where, you know, the patient's, it's now a month into the patient's illness on ECMO, and we just kind of say, well, I'm going to lower my expectations about caring about this so much, because obviously there are other types of patients, like patients with pulmonary fibrosis, who have high works of breathing all the time, and they somehow get through it. So I think after a certain point in ARDS patients, there's a transition from where we have to be obsessive about preventing ventilation-induced lung injury to where the trade-off of all the things that we do to try to mitigate that become too great, and we have to just accept that some of this might happen.
Mm-hmm. Professor Papazian?
As Daniel said previously, paralysis is not a religion too, and probably for some patients, by adjusting PEEP, as Neil said previously, and by adjusting inspiratory time, you can decrease the risk of severe ventilator-induced lung injury. But sometimes, and many times, we have also to adjust sedation to decrease such a risk. And sedation, in many times, is sufficient to provide a good interaction between the patient and the ventilator. And when sedation and ventilator adjustments are not sufficient to improve the synchrony, in this case, we paralyze the patient. But our first action generally is not to paralyze patient, but first to adjust ventilator settings, and eventually by increasing sedation level, for example.
Professor Talmor?
So clinically, I don't really have anything to add to what Neil and Laurent said. I will say that Neil and group have brought up this very interesting concept of diaphragm protective ventilation or sedation, and I would say that we should be looking at lung protective sedation. And most sedation trials target RASS score or delirium post-ICU stay, but they don't really target how well they bring the patient into synchrony with the ventilator. And it may be that there are specific sedation regimens which are better or worse. We just don't know. So, you know, I could see, for example, high opiates reducing respiratory drive and bringing patient into better synchrony, but it's never been studied in that way. So I think a challenge for all of us is to think about sedation in terms of synchrony and not just in terms of RASS scores and post-op delirium or whatever. So that's probably a new challenge for the entire field.
Mm-hmm. Another question from the audience. Do you use very often inverse inspiratory-expiratory ratio? Neil.
I understood the question. Do we often use inverse ratio ventilation? Yeah. I would say not commonly. What that does is generally it creates the setup for intrinsic or auto PEEP, which you know, that can be helpful, but in terms of oxygenation in some patients, but it's not. It may be more heterogeneously applied, and it's not as easily measured or documented as just setting PEEP. So I think sometimes you're fooling yourself thinking that on keeping pressures low by going into inverse ratio ventilation, whereas if you actually measured true plateaus and true total PEEP, it would be higher than you were documenting. So I prefer just to stay at 1-to-1 or less, avoid significant auto PEEP, and just set PEEP that's going to be present.
Professor Papazian?
I fully agree with the comments done by Neil, and there is the risk of autopip. It's an interesting technique, but only for a few patients in order to improve oxygenation, for example. But we have to be sure that there is no progressive increase in CRF due to the autopip and underestimated level of total PIP with subsequent hemodynamic risks. So my my point of view is that it's only for very few patients.
Mm-hmm. Professor Talmor?
Yeah. So inverse ratio ventilation increases the mean airway pressure, which will improve oxygenation pretty predictably. But as both Neil and Laurent said, it gives you unpredictable pressures in the lung, possibly injurious pressures. And really, I would try to avoid it and go one step further and say that, you know, modes like APRV, which are essentially extreme inverse ratio ventilation, do the same thing. They improve the oxygenation, but possibly injure the lung at the same time.
Mm-hmm. There are two questions from the audience about APRV and recruitment maneuvers. Do you use it continually?
So I'll go first if
Okay.
let Neil off the hook. We very rarely use APRV in our practice. As I said, it will improve oxygenation, but it leads to really unpredictable pressures in the lung and possible lung injury. And it's important to remember that there are many variants of APRV in the literature. And if you are going to use it, you need to be sure that you know what you're doing, because it's been described in many, many ways. Regarding recruitment maneuvers, we do use them and think they're useful. And I'll put in my obligatory plug for transpulmonary pressure. This is another area where targeting the ventilator to transpulmonary pressure makes much more sense. And we've shown that the transpulmonary pressure delivered in a recruitment maneuver may be very different from the pressure you think you're delivering at the airway.
Professor Papazian?
Yes, we also use sometimes APRV, especially when patients present very strong respiratory effort with an important respiratory drive, and with the lack of synchronization between inspiratory effort and delivery of tidal volume. It's methods that can decrease large swings in transpulmonary pressure. But it's, as Danny said, it's we have to be cautious with this technique, and it is important to very well know all settings to adjust perfectly the different level of pressure. And we have also to say that when patient makes spontaneous effort, there is no help, there is no pressure support, and very small tidal volumes are generated by the patient. Regarding recruitment maneuver, we are doing recruitment maneuver only when there are severe derecruitment.
And we also very rarely, if ever, use APRV. I think it's important that there is a big distinction in terms of how you use this mode. If it's set up in what I'll call American trauma surgeon mode, which is extremely long time at the high pressure with short releases to facilitate down to P's of 0. P-lows of 0, then I worry again that that's not a lung protective mode for several reasons. Using it essentially like IMV in intermittent mandatory ventilation, as Laurent, I think, was describing, maybe a different, almost a different mode of ventilation entirely. We also do recruitment maneuvers in, not in everybody, but in more severe ARDS patients, but do them carefully and with close attention to hemodynamics at the same time, and we try to avoid these long staircase type maneuvers.
I'd like to thank you, all of you, for the excellent discussion, and our time ends. So thank you for the excellent discussion.
Thank you. It was nice
Thanks
to meet you.
very much.
Yeah.
Nice to meet you.
Good to see you guys.
Yeah, hopefully see each other soon.
Yeah.